Hello everyone and welcome back to the channel. If you recently had a blood test and your doctor has told you that your ANA test is positive, you're probably feeling worried. Perhaps you've searched online and immediately seen words like lupus, autoimmune disease or connective tissue disease. Maybe you've been referred to a rheumatologist, or perhaps you're simply wondering whether this blood test means you have a serious illness. The good news is that a positive ANA test does not automatically mean you have an autoimmune disease. In fact, one of the biggest misconceptions I see in clinic is that people assume a positive ANA equals lupus. That simply isn't true. In this video, I'm going to explain exactly what an ANA blood test is, why it becomes positive, what diseases it may be associated with, why many completely healthy people have a positive ANA, what further tests might be needed, and most importantly, when you should actually worry about the result. I'm Dr. Naveen Bhadauria, consultant rheumatologist at Pure Rheumatology, London. Let's start with the basics. ANA stands for Antinuclear Antibody. As the name suggests, these are antibodies produced by the immune system that recognize structures found inside the nucleus of our own cells. Normally, the immune system is designed to protect us against infections such as bacteria and viruses. In autoimmune diseases, however, the immune system becomes confused and starts recognizing parts of our own body as foreign. Antinuclear antibodies are one example of this process. Now, hearing that explanation, you might think that anyone with a positive ANA must have an autoimmune disease. Surprisingly, that's not the case. One of the most important messages I want you to remember from this entire video is this: a positive ANA is not a diagnosis. It's simply a laboratory finding that needs to be interpreted alongside your symptoms, examination, and other blood tests. In fact, many completely healthy people have a positive ANA. Depending on the laboratory and the strength of the result, somewhere between 5 and 20% of healthy adults may have a positive ANA without ever developing an autoimmune disease. The likelihood also increases as we get older, and low-level positive ANA tests are more common in women than men. This is why rheumatologists never diagnose lupus or another autoimmune disease based on the ANA test alone. Think of the ANA as a clue rather than an answer. It's one piece of a much larger jigsaw puzzle. The next obvious question is why your GP requested the ANA test in the first place. Usually it's because you've developed symptoms that could suggest an autoimmune disease. These might include persistent joint pain, prolonged morning stiffness, unexplained fatigue, mouth ulcers, skin rashes, Raynaud's phenomenon where the fingers change color in the cold, dry eyes, dry mouth, unexplained fevers, hair loss, or inflammation affecting different organs. When these symptoms are present, an ANA test can help guide further investigation. However, if someone has no symptoms whatsoever and simply happens to have a positive ANA, the result is often much less significant. So which diseases are associated with a positive ANA? The condition most people have heard of is systemic lupus erythematosus, or lupus. More than 95% of people with lupus have a positive ANA, making it a very sensitive test. However, this doesn't work in reverse. Most people with a positive ANA do not have lupus. That's an incredibly important distinction. ANA positivity can also occur in Sjogren's syndrome, systemic sclerosis or scleroderma, mixed connective tissue disease, inflammatory muscle diseases such as dermatomyositis and polymyositis, undifferentiated connective tissue disease, and less commonly, rheumatoid arthritis. Outside rheumatology, positive ANA tests may occasionally be seen in autoimmune thyroid disease, autoimmune liver disease, and even after certain viral infections. Certain medications can also cause what's known as drug-induced lupus, which may be associated with a positive ANA. Fortunately, this is relatively uncommon and usually improves when the medication is stopped. Patients often ask me, if my ANA is positive, does that mean my immune system is attacking my body right now? The answer is not necessarily. Many people have these antibodies circulating in their bloodstream without any evidence of tissue damage or inflammation. This is another reason why the ANA test must always be interpreted in context. Let's now talk about the ANA titer, because this often causes confusion. When you receive your blood results, you may see numbers such as 80, 1 in 160, 1 in 1320, or even higher. Generally speaking, the higher the titer, the more significant the result may be, although this is not an absolute rule. A low positive ANA such as 1 in 80 is relatively common in healthy individuals. Higher titers are more likely to be associated with autoimmune disease, particularly when accompanied by compatible symptoms and additional antibody tests. However, even very high ANA levels do not diagnose lupus on their own. This is where the next stage of testing becomes important. If someone has a positive ANA and symptoms suggestive of autoimmune disease, we usually perform more specific antibody tests. These include antibodies such as double-stranded DNA, often abbreviated to dsDNA, which is strongly associated with lupus. We may also request an extractable nuclear antigen panel, often called an ENA panel, which looks for antibodies including Rho, LAR, Smith, RNP, SCL70, and JO1. Each of these antibodies provides additional information and may point towards particular autoimmune conditions. We may also check complement levels, inflammatory markers such as ESR and CRP, urine tests to assess kidney involvement, full blood count, liver function tests, and kidney function depending on the clinical situation. As you can see, that ANA is rarely the end of the investigation, it's usually just the beginning. One question I hear regularly is whether the ANA should be repeated. In most cases, the answer is no. Once the ANA is positive, repeating it over and over again rarely provides useful information. The level may fluctuate and doesn't necessarily reflect how active an autoimmune disease is. Instead, we monitor the patient's symptoms and, if necessary, more specific blood tests depending on the diagnosis. Another common question is whether lifestyle changes can make the ANA become negative. The answer is generally no. The ANA itself isn't something we aim to treat. We treat the underlying disease if one is present. If someone has lupus, for example, our goal is to control inflammation, protect organs, and prevent disease flares, not simply to change the ANA result. Let's talk about what happens when someone is referred to a rheumatologist because of a positive ANA. One of the first things we do is take a detailed history. We want to know exactly what symptoms you've been experiencing, when they started, and whether they fit the pattern of an autoimmune disease. For example, do you have prolonged morning stiffness lasting more than an hour? Have you developed mouth ulcers, unexplained rashes, or sensitivity to sunlight? Are your fingers changing color in the cold? Have you noticed dry eyes or a persistently dry mouth? Have you experienced chest pain when taking a deep breath, recurrent fevers, or unexplained weight loss? These are often much more important than the blood test itself. We then perform a thorough examination looking for swollen joints, skin changes, muscle weakness, enlarged glands, or other clinical signs that might support a diagnosis. Only after putting together your symptoms, examination findings, and blood tests can we decide whether you truly have an autoimmune disease. Sometimes patients leave clinic relieved because we can reassure them that the ANA is an incidental finding and doesn't require any treatment at all. Other times the ANA helps us identify an autoimmune disease early, allowing treatment to begin before significant damage occurs. So when should you actually be concerned about a positive ANA? You should seek medical assessment if your positive ANA is accompanied by symptoms such as persistently swollen joints, prolonged morning stiffness, recurrent mouth ulcers, unusual skin rashes, photosensitivity, unexplained fever, significant fatigue, muscle weakness, Raynaud's phenomenon, chest pain, breathlessness, or unexplained kidney problems. These combinations of symptoms deserve proper evaluation by your GP and, where appropriate, a rheumatologist. On the other hand, if you feel completely well and a low positive ANA was discovered incidentally, there's a good chance it may never cause you any problems at all. Finally, I'd like to address something I see far too often. Patients sometimes receive a positive ANA result, search the internet for 5 minutes, and convince themselves they have lupus. This understandably creates enormous anxiety. Please remember that the internet tends to show the most serious possibilities first. In reality, rheumatologists diagnose autoimmune diseases by looking at the whole clinical picture, not a single blood test. So if you've recently been told your ANA is positive, don't panic. A positive ANA is an important clue, but it is not a diagnosis. Many healthy people have a positive ANA, and many never go on to develop autoimmune disease. What matters most is whether the blood test fits with your symptoms and the findings on examination. The key message I want you to take away today is that blood tests should never be interpreted in isolation. Medicine is about putting all the pieces together. That's why seeing an experienced clinician is so important. If you found this video helpful, please like, subscribe, and share it with anyone who may have recently received a positive ANA result. For more videos on lupus, Sjogren's syndrome, rheumatoid arthritis, autoimmune diseases and rheumatology, please don't forget to subscribe to the channel. And if you would like a specialist consultation, I see patients at Pure Rheumatology London. Thank you very much for watching.